So in this video, I will talk about massive transfusion protocol, which is an very important entity, especially with regard to transfusion during trauma or obstetric hemorrhage or sometimes intraoperative hemorrhages. To understand massive transfusion protocol, especially for people who have not seen my other videos, I will just recapitulate the component therapy in one slide. But however, I would recommend you to go back and check the other video on blood components. So when we talk about blood components, we have PRBCs, platelets, fresh frozen plasma, and cryoprecipitate. Okay. And mind you, you should understand that especially in these components, especially PRBCs will be usually divided of both platelets as well as all the clotting factors. Mind you, even if you transfuse whole blood, once it is refrigerated, most of the platelets or especially the labile clotting factors will not be available in a refrigerated whole blood. Of course, if it's a fresh whole blood unrefrigerated, you can expect them to almost have everything, but the logistics are different and usually used in military and other scenarios only. So what I want you to understand here is, whenever we have these components, especially with PRBCs or the platelets, actually there is no prior preparation time required, in the sense other than for pre-transfusion testing, the product can be retrieved and utilized. Whereas fresh frozen plasma and the cryoprecipitate are usually in frozen state, and there is some preparation required. That is, you have to bring them for infusible state from the frozen state by thawing at 37 degree. And this really requires a preparation time. So why that is important is, whenever you make a request for these products, you should anticipate that there should be a time allowed for the preparation of this product, especially FFP and cryo. So that is where the concept of massive transfusion protocol will come into the picture. So now, what is the definition of a massive transfusion? If you see books, they are variedly described as either a replacement of one blood volume within 24 hours, or transfusion of more than 10 packed red cells, or more than 4 packed red cells in 1 hour with ongoing bleed, or even 50% of total blood volume within 3 hours is replaced. But what you should understand is, all these are retrospective definitions. That means to say, you can call it a massive transfusion only after more than 10 units have been transfused within 24 hours. So what is the problem with these kind of definitions is, it may be helpful in the research protocol and all, but not in active patient management. In active patient management, you will have to anticipate a massive blood loss or a massive transfusion, and you have to act accordingly. The same with the pediatrics. There are definitions for pediatrics like transfusion of more than 50% total blood volume in 3 hours, or transfusion of more than 100% total blood volume in 24 hours. So the one which is more proactive is this, what I have given here, probably a bleeding of more than 150 ml per minute. So that is where you define, okay, this is a massive blood loss or requires a massive transfusion, and you have to act accordingly. So now, whenever you transfuse somebody, why this unit of more than 10 packed red cell or 4 packed red cell is given is, whenever you transfuse with such large volumes of blood, you should understand that this blood is practically devoid of any platelets or the clotting factors. So when you give this much amount of blood to a patient who is bleeding or anything, at the end of this much transfusion, it creates what is known as dilutional thrombocytopenia or a dilutional coagulopathy, because you have replaced his blood volume only with packed red cells with no component of clotting factors or the platelets. So this dilutional effect is what causes all the problems related to massive blood loss. So with that understanding, we'll go ahead. Though it is says trauma, it also synonymous with other kinds of bleeding like postpartum hemorrhage or even an intraoperative bleed. So once a patient bleeds so much, there sets in what is generally called as the triad of that, that is coagulopathy, decreased heart performance, okay, decreased coagulation and increased lactic acid in the blood. So this leads, one leads to the other. Coagulopathy leads to acidosis, acidosis leads to hypothermia, and hypothermia again leads to coagulopathies. And once this triad is sets in, the patient course will usually go downhill. So the whole intention of a massive transfusion protocol will be to break this triad and revive the patient. So just to have an understanding of this, whenever a patient have a trauma or an insult, there is a tissue damage which leads to blood loss as well as lot of release of cytokines and the hormones. So that by various other mechanisms like activation of fibrinolysis, consumption of coagulation factors, it leads to what is known as traumatic coagulopathy, and that triad of includes acidosis, hypothermia, and all that. So to break this, we need what is known as massive transfusion protocol. So why massive transfusion protocol? The massive transfusion protocol helps you in an effective blood management of the patient. It helps us in an effective response to the injury. It produces increased survival and prepared us for such instances in future. Development of an actual SOP based on the evidence and allows you to have a rapid response in these situations. So, in a massive transfusion, the whole massive transfusion protocol is actually a preparedness for a something like this. When a patient goes into massive bleeding, either anticipated or unanticipated, it's a protocol that helps you to get all these blood products in time so that you can affect the patient in a positive way by not allowing him to going into that triad of death. So what is the evidence, or why did we get this concept? People noticed, especially this landmark paper, which was brought about from the war of Iraq in 2003, whenever they randomized into 3 groups who received 3 ratios of blood groups, blood components, that is low, that is 1 plasma per every 8 units RBC transfused, and in the medium ratio, that is 1 plasma for every 2.5 RBC units, and in the high proportion group, that is 1 plasma for almost every 1.5 RBCs. And they noticed that whenever the proportion of plasma to RBC was higher, the survival was almost 19%. I mean, the death, which was 65%, which decreased to about 19%. So that is when they realized the actual importance of transfusing plasma beforehand or in the upfront. There are also other papers which came. One is called the PROMPT trial, where they again they transfuse plasma to PRBC in a ratio of 3:4, and the other one and what this was the population, and what they actually got is the 24-hour survival and the 30-day survival. They noticed that the response or the survival was 1.97 or 2.25 in the 24-hour by maintaining a high plasma to PRBC ratio. They could, it was associated with an improved survival. This is another, which again, it was done on civilian trauma patients randomly assigned to receive 1:1:1 or 1:1:2. So here you have to understand that when we say 1:1:1, that means 1 unit of PRBC to 1 unit of FFP to 1 unit of RDP. Okay. 1 unit of RDP. So usually, or if at all, if we are giving P6 PRBCs, then it will be 6 FFPs and 1 unit of SDP, as I already told. Usually 1 SDP is sufficient, equivalent to about almost 6 units of RDP. And they also noticed here that more patients in 1:1:1 group achieved hemostasis and experienced fewer death. Okay. So this is all what gave rise to the concept of massive transfusion protocol. I will not go into more details of that one here. It's more about how to define a protocol and have it used in your system. So this is another which is called as the PAMPER trial, which showed that pre-hospital plasma for trauma actually improved the 30-day mortality significantly in the plasma group when compared to the control group. Okay, so to make an understand of this protocol, this massive transfusion protocol is something that you have to set up in a hospital by the conformance with the surgeon, anesthesiologist, and all the trauma team who are involved with the blood center director, so that you are prepared for such an instance if happens in future. Okay, this should be made an SOP, validated, and should be put into use in a hospital. So what is the background? For example, you have to know the turnaround time required. Whenever you ask for an uncross-matched RBC from a blood center, you can get it in almost within 5 minutes. But when you ask for an ABO and RHD typing only, the turnaround time is around 15 minutes. And if you want a proper type and screen as well as cross-match, either serologically or e-cross-match, this is the time that you 60 minutes or more than 120 minutes in a complete pre-transfusion testing. So now why I have put this is for you to understand whenever you have a situation wherein it requires a massive transfusion, this turnaround times could be detrimental. You cannot wait for an 120 minutes or even a 45 minute. Okay. Many a times it's possible that you may not even be able to wait for a 15 minute. Okay. So now whenever a massive transfusion protocol SOP is set up or activated, it is understood that you usually get uncross-matched RBCs. That means to say you don't even ask for a patient sample. The moment you inform the blood center that you are activating a massive transfusion protocol, the blood center issues the blood products, generally OPRBCs or the AB plasma in the first, okay, around 4 to 6 units immediately without all this pre-transfusion, and immediately issues them, and it reaches the patient site within 5 to 10 minutes. That should be the whole rationale for using. Okay, whenever you activate a protocol, this is how it works. These uncross-matched blood products will reach the patient site as early as possible. And whenever we talk about giving out of group, people ask is the what about the reaction? So this is the risk of hemolysis that is generally known. In uncross-matched RBCs, the risk is about 5%. And in the cross-matched completely, it is less than 0.1. But what you have to understand is the importance of giving the blood products to the patients immediately. Okay. So whenever you understand that I don't have time to go for all these things, so sometimes you will just draw a sample or may not even draw a sample. You directly ask the blood center to release these units. And all the other things like drawing the sample and will happen simultaneously. And once the blood bank receives this request, they will give the blood products. So there is something called as a management bundle when you handle massive transfusion. The bundles are something like this. One is called the pre-hospital bundle. That is when the patient receives some treatment even before reaching the hospital. Then there is a bundle for intra-hospital, how you handle like do a blood count, prothrombin and all that. And there is a coagulation bundle. I'm not going to details of this, but what we have to understand is this. So this is an example of a massive transfusion protocol in an obstetrics. So what happens is whenever you find a patient exsanguinated or something, you request the blood center to release the first round of massive transfusion protocol. So this is how something a massive transfusion protocol kit looks like. So it will have RBCs about say 6 units, and then it will have FFPs another 6 units, and platelets, okay, around 6 units. You can add 10 units of cryo if you want. So all these are issued immediately once the blood bank receives a request in as a single pack. So that is called round 1. So once this is released, the treating team utilizes this and transfuses immediately and makes an assessment of the patient. And by then, probably you would have picked up a sample, you have sent them for testing, you have probably even had the grouping done for this patient. By the time you have transfused. Once the grouping is done, probably you can switch over to the patient specific group. So you reassess the patient after this round 1 and again as for round 2. So again in round 2 you ask the blood center issues around 6 units of RBCs, FFP and platelets and so on. And after every round you reassess the patient either clinically or laboratory, whatever is feasible and the your center allows you to do and so on. In usually obstetrics nowadays, with the trials that have shown tremendous improvement following tranexamic acid, round 3 is usually you give 1 gram of intravenous trauma over 10 minutes and again it continues. So after each round you assess the patient condition and then either terminate the massive transfusion protocol by calling the center and telling that they are terminating it, or you ask the cycle to continue. And that is how a massive transfusion protocol works. So this is another passive transfusion protocols used in some other settings other than obstetrics. This rationale is similar. Like you have a first pack where RBCs, 4 RBCs and 3 FFPs are sent and so on. So each hospital can prepare their own protocol, which is agreed upon by all the stakeholders and put it on an SOP. And that is how a massive transfusion protocol is. This is called the protocol and that is put in place. And whenever, so there should be clear guidelines as to who will activate the protocol, who will the protocol be conveyed to, and who will terminate the protocol and all that. So you have to make an SOP for your setting, and that is how the massive transfusion protocol works. So we all know that whenever, especially for blood centers, is a big headache, especially the AB plasma, given that our prevalence of AB is very less than 3-4% in most of the population. Getting an AB plasma can be a headache. So for a successful massive transfusion protocol to run in bigger institute, it's always better that you have a policy that you, as early as possible, maybe a bedside grouping can be sometimes if required, to ascertain the patient's blood group, and you have to switch to type specific PRBCs or the ABs or the plasmas as soon as possible. So to conclude, so massive transfusion protocol is a policy put in place so as to get the blood products in times of emergency, especially when the patient is having an anticipated massive blood loss or there is an ongoing blood loss. So you put a protocol in place. So who will activate the protocol? What will you base the activation on? Whether it's going to be clinical or you're going to have some bedside or what is known as the test which can be done at a faster point of care testing like TEG and all that has come. So what are you going to base them? Have an SOP in your place, and who will activate it and who will terminate it, all these things. So have a massive transfusion protocol in place that everybody agrees upon. And the crux of a massive transfusion protocol is to get these blood products as early as possible. Okay, so which will not have any pre-transfusion testing and so on. So I will leave it there. Thank you.